There you go. Now, Dale, you'll have it. Frank started it.
Okay.
I still don't see it more.
And then
Oh,
it'll
I
at the
see it
very
now. I see it now. We've got it. Okay.
Well, I have 8:31,
I
so
do too. Yeah. You want to start? You want me to?
I can go ahead and start it as long as you turn it over to the video over to Frank.
I'll take care of that.
Okay. Well, good evening, everyone. Good to see you. Thank you for carving out a little bit of time to join us tonight. Um, if you would keep yourself muted until you're recognized to speak, that way we won't have any distractions in the background. And then along the way, if you would like to interact or near the end, uh, there's a hand icon. If you would use that hand icon and recognize that, we'll recognize that and call on you then to interact. Let me begin and thank the Lord for the gift of this day and the opportunity we spend a little time together. Okay. Again, our Lord, we thank you for each person, where they're located, their sphere of ministry, and we thank you for your good hand of blessing on them. And as we gather tonight, help us as we interact and to think clearly and to ultimately become more effective in our ministry to our comrades and their families. In your name, amen. Uh, Over the last couple months, if you think back with me, I started and we did a session on attending when we meet people at our post or someplace to give ourselves entirely to being with them and to attend to them. And so we had a session on attending, and the whole idea was to develop our listening skills and become better at listening and attending to other people. Um, then I showed a little bit of how stress is related to problem development. You can't avoid stress, but when you have prolonged stress, ultimately you can almost predict what's going to happen uh, uh, with individuals. There will be personality. Uh, Depending on their personality, there's certain traits that will be evident. And when the stress continues, there'll be physical issues that happen as well. So the role of stress in problem development. And so when I'm in a post and I know somebody's under extreme stress for a long time, you can almost see a progression as they move through and problems develop. Um, but anyway, then we took a little break and did a session on different faith groups and different religions. And then Frank also did a session on dashboard reporting. Um, since the reports no longer come to jot form, they're supposed to go into the dashboard and then ultimately up to national through there and combined with the community service reporting. So, and then Jim Jenkins did a session on knowing when to refer. And last month, how to understand and assist those who are grieving. So tonight, I'd like to take a focus and put it on our hospital and care ministry. From time to time, we're going to have people enter care facilities or hospitals, and we will be called upon to go visit them. And so this is hopefully will help us. Now, some time ago, we mentioned that there is an organization in Florida that developed christianleaders.org, christianleaders.org, and they have a series of courses, biblical courses, other courses, and then there's a series of courses on chaplaincy. And some individuals in our group have taken those courses and really found them helpful. Right after we introduced you to christianleaders.org, I went on the site because I wanted to check it out. And I started observing what they had in their counseling area. All courses are free, but if you want to eventually get a degree or get some certification, I believe there is a fee for that. So I went on and I started looking at these courses, and I found that they're really well done. And one thing I came across that I thought was really helpful was a church in Hawaii. A church in Hawaii was training their people to do hospital ministry, and it was a Calvary Chapel church in Hawaii. And I found that they really had some good stuff. And so I put it in the back of my mind that I wanted to go back and review it and things like that. And I thought maybe I would bring that video in and just share the video. However, when I went back and looked at it, while it had a lot of good information, it was not well done. It was just not professionally done. And so you can get away with in the church, but for our purposes here, I did not feel that it was not the quality. While the content had some good content, the quality was not there. And so what I decided to do is I decided to go through that and pick out some of the good things that they presented and add that to a video PowerPoint presentation that Frank and I have been working on. And so Frank, if you would want to get that up at this time, the PowerPoint, that would be good. Now, what I did is I sent out to you a 2-page handout entitled Hospital or Care Facility Ministry Guidelines. And that 2-page paper is a summary of what that video series was that I looked at from Hawaii at Calvary Chapel in their presentation. So well, as we begin here, Frank, go to the next one. Yeah. This whole presentation deals with hospital and care facility ministries. Okay, next one. Now, when you look at hospital or a care facility ministry, the first question to ask is what hospital ministry is. What is it? And basically, it's an on-call ministry. Our role in visiting a hospital or care facility is basically an on-call ministry. In other words, we will be notified when there is a need to visit someone, and we will respond accordingly and go to the hospital or care facility. We've all done that. It's about extending care, and while we're there, we're going to provide comfort and support those in that face the challenges of being in a hospital. Now, what it is not. Next one. This hospital ministry is not a time or place to engage in theological or philosophical discussions. So anytime you visit in a hospital or care facility, You got to keep in mind this is not the time to engage in any philosophical or theological discussion. We are there to focus on the patient's emotional and physical well-being rather than engaging in some deep theological or philosophical conversation. Next one. Sometimes a patient in a hospital will ask us, chaplain, or pastor, why is this happening? If asked why, a simple and honest answer could be simply, I don't know. But I am here because I care. In other words, you do not want to be brought into discussion of some philosophical or theological discussion as to why this is happening or the role of God in all of this at this particular time. We are there to support the patient, and a simple and honest answer is simply, I don't know, but I am here because I care for you. Next one. The thing to keep in mind in doing any type of care or hospital ministry is just being there is the most important part of the visit. The fact that you show up, by your presence, you have a chance to extend care and comfort to a comrade or a comrade's family. So showing up and being there is the most important thing. And also remember that we are representing not only ourselves, but also our VFW post, our VFW family. And so when I go to visit someone who's part of the post, is I usually try to bring greetings from either the commander or somebody in the post. I might say, oh, by the way, Bob, Sharon was thinking about you. And when she found out I was going to come visit you, she said, oh, send greetings. So I usually try to build a bridge between myself and the post family and people that they know in the post. Next one. Now, I've made many mistakes. And this is a simple slide about preparing and preparation for the visit. First of all, gather information. And in the past, I have not written down the person's name fully. So what I do now is I make sure I write the person's full name. You don't want their nicknames. You don't want Junior or anything like that. You want their full name. Also, I try to obtain names of their family members, their spouse, any other family members, and I try to put those down so that I have a frame of reference of who this person is that I'm visiting, their family and relationships and things like that. Now, I also try to make a note and write down who notified me and asked me to visit. Your sister Sharon said something to me or asked if I could stop by and visit you, Bob. And what that does is that bridges the gap. And so whoever asked me to visit or notified me, I try to write down their name. So I have all this information on a little note card, so I have that right before me. And then gather information about the facility. Where is it? Sometimes facilities have there might be 3 locations, one name, 3 different locations. You want to make sure you're going to the right facility. So you want the name, your phone number, the room number, the reason for your visit. Write everything down. And for me, I have to tell myself to print it clearly so I can read it when I look at it later on. Next one. If you're going to go visit, you have to make sure you dress appropriately, look professionally. Remember that you're representing yourself, your post, your VFW, the extended VFW. And so you don't have to wear a coat and tie or anything like that, but you have to dress appropriately and look professionally. And next one. Now, recently, I showed up at a care facility because there was a 92-year-old Jewish war veteran who was a patient there, and I was told that he was there. I did not call the facility right before I departed. So I showed up, I walk in, I walk up to the desk, I said, I'm here to see so-and-so. And the person looked at me and they said, he's not here. He's over, and then he was transferred to a hospital. So from the time I was notified that he was at the facility to the time I got there, he had already been transferred to a hospital facility. So now it's very easy just to make a call to the facility and ask, is so-and-so still there? Get the room number and things like that. And then if he's not there, they will many times over the phone be able to tell you where he was transferred to. So I always make sure I take a business card. I also take a note card in case they are not in the room at the time I'm visiting. I can always write a note. Now, so you get to a hospital or a care facility, the first thing you want to do is you want to go up to that desk that handles the patient care. You want to identify yourself. Hi, I'm Peter Hook, the chaplain at so-and-so post, and I'm here to visit so-and-so, and I understand he's in room such and such. Is he still here? And is he in that room? And the person will look up the person's name, and they will confirm either that he's there and that he's in that room and so forth. So I always stop by, identify myself, and then they're the ones that will give you directions to the room. And trust me, in many of these hospitals where they added on over the years, you want a map if possible. If they don't have one there, most of them have a little map. They will draw and say, oh, you go down here, and it's not that elevator, it's the next one. And they will draw a little map, tell you how to get there. Make sure you listen carefully, write it down so that you don't get lost on the way. So at that point, I think at this point, Frank, if you want to take over.
Okay. Oh, my slides don't want to advance. There we go. Just a few thoughts on hospital visitation or care facility visitation. Just some key things kind of to back up what Peter was saying, be patient-centered. Healthcare professionals, especially in mental health, they'll say client-centered, but you know what I mean, the person you're visiting. It's about them, not about me or my agenda or anything like that. And we've had in one of our classes in the past, listening skills. And this is, where those skills come into play, because we need to, focus on hearing and reading between the lines, observing their nonverbal communications, those kind of things. I know this is obvious, but, don't sit on the bed. That's for contamination purposes, but also sitting on the bed could cause the bed to shake. And if they've got, pain or wounds, that could be pretty painful. Avoid shaking or holding hands unless the person wants to. And again, that's being client-centered, what they're comfortable with. You don't want to impose your feelings on them. Now, the slide says, don't ask them about their condition. In other words, don't try to get all the dirty details. You can say, hey, how you feeling? How's it going? They want to talk about it. They may open up the conversation. That's fine. but it needs to be what they're comfortable doing. Something about visitation etiquette, just, knock on the door first, because you don't want to disturb the patient. Maybe they're having a procedure done. Maybe they're getting a bed bath. They might even be asleep. Those are things you don't want to disturb. Maybe the doctor is visiting them. They're having a private conversation, those kind of things. So you want to be mindful about privacy. So that might be a case where you might need to wait outside the door until they're finished before you pop into the room. What about meal times? Be sensitive to that. Maybe you timed it wrong or you didn't know. But if they're eating, just say, hey, I'll come back in 15, 20 minutes. I think put yourself in their position. If you were eating your meal and you're maybe a little queasy, you don't feel good, you don't want somebody watching you eat. That's uncomfortable. It's not like you're going out to lunch together. Maybe eating is difficult. So, just say, hey, I'll just come back, give you some time to eat in privacy. That's probably a good thing to do, and is a very considerate thing to do. Again, just try to put yourself in their place, how you might feel. And then becoming familiar with hospital signs and symbols. I think, Peter, we got different PowerPoints here, so I gotta try to get synced here. So we'll go back to that. Something on the changing nature of healthcare. And this is particularly difficult for our patients that are maybe in their 60s and above. Healthcare has changed drastically. I spent about 40 years in the healthcare field, both civilian and military, and I myself have seen some pretty major changes. Those of you that are older know what I'm talking about. I'll give you an example. An appendectomy used to be about a week stay in the hospital. Gallbladder removal used to be a standard 10-day hospitalization. Now both of those surgeries are done laparoscopically. You go home the next day. So it's very, very different now. And then, of course, managed care, that frustrates people because the insurance companies and such, they dictate who the doctor is and what your options are, how long you stay. Everything's controlled and managed by higher ups. And that can be frustrating for, family members that think, well, I'm not ready to take care of this person. I think, why don't you just keep them a week? Well, it doesn't work that way. So that could be really scary and frustrating to people because it's not the way it was when they grew up, in other words. And because of the budgetary constraints and all the technology, one of the effects it has is there's a definite decrease in personal touch. Speaking as a former nurse myself, you'd have more time to look people in the eye and the more personal touch in the past. But things are different because the average hospitalized patient is so much sicker now, and they have a very short hospital stay. So it used to be you can go into hospital and they're several days post-op, they're feeling more up to conversation, etc. Now when you see the patient, they're probably at their worst and in pretty bad shape. And it's on the average, a typical patient's in a lot worse condition than maybe 40 years ago when you were visiting somebody in the hospital. So maybe not what you're used to seeing, or maybe what you're not expecting. The other part of the decrease in personal touch, everything's computer-based documentation, electronic personal records. And if you've been to the hospital or even a doctor's visit, they're talking to you, but where are their eyes? They're not making eye contact. They're looking at the computer and typing away madly while they're talking to you. And that comes across as very disconnected, maybe impersonal. And that's just by the nature of the beast. They're doing what they have to do to be able to have the patient turn over and move quickly, and they have to document it on the computer, because if it's not documented, it's not considered done. And so while all those things are frustrating for the patients, there's some definite implications for us, and that is we have an opportunity to provide more of that eye-to-eye contact, a more personal touch. It may be a little different. We're not going to be in as big a hurry as maybe the hospital staff are. It's not their fault, but they're just overloaded. So if we come in a little more calmly with more time and provide a more personal touch, more individual thing, that could be a great opportunity to bless that person you're visiting. One thing to back up what Chaplain Peter said about how you dress, I try to wear like a polo with the VFW logo of some sort and my name on it. Not only did that identify who you are and who you represent, then the staff will see who is this person, why are why are they here visiting, and that could be a good thing. In fact, that might open up some doors because you might even ask the nursing staff, hey, are there any other veterans here that you think might like a visit? You never know. That might be a possible opportunity. They tend to be pretty strict about controlling who goes in and out of the rooms, but you never know. They might know somebody, hey, there's a veteran there that's pretty lonely and he would probably like a visit. So that could open up some possible doors. Remember, you don't have the right to visit all the patients. It's a privilege. It's a lot stricter than it used to be. But again,
Frank, let me jump in here. What I notice is that when I go onto the floor where the nurse's station is, and I have something that identifies me, and I explain that I'm Peter Hook. I'm a chaplain with a VFW, and the family has requested I come and visit so and so. I'm actually bridging who I am and who I'm going to visit and why I'm there. I'm not just popping in on my own, but generally I am there because the family or so and so requested a visit, and they really honor that and they respect that. So anyway, go ahead.
That's a very polite thing to do too. That way they know who you are and makes them more comfortable too. So that's a really good point. And as far as how you present yourself and the fact that what Peter just shared about visiting, I think that's a great opportunity to promote the VFW, what we're trying to do, because there's a conception out there by a lot of people that VFW is just a bar with a bunch of old guys smoking cigarettes and being drunk, nursing their alcoholism. That's something we're trying to overcome. And so here they see that, hey, they provide something else, something of value. So we have an opportunity to kind of change their perceptions that are out there, unfortunately. I want to talk about acute care visits. Acute care meaning, the basic hospitals as opposed to a nursing home or something of that nature. Keep in mind that it is a very different culture. The medical field has its own language. I think I don't even need to explain that one. Remember that you're on their turf. They've got a very busy environment, high stress. They need to protect the patients. So remember that, this is not like they're coming to visit you at your house. You're visiting them at their place of business, which is a very high stress place. So some of the things we can do to help, abide by the rules, like visitation hours, any signs you might see. Most ICU and acute care hospitals are going to ask you, hey, try to keep the ICU in particular, keep your visits, very brief, like 10 minutes. Peter mentioned here, keep it down to 5 minutes. That might be the appropriate thing. Just use good judgment, because oftentimes it's maybe the family that you're going to spend time with down in the cafeteria, have an extended conversation as opposed to at the bedside. So, be guided by what you hear and what you see. Now, as chaplains, we're considered like quasi clergy. Some of you are clergy, but you do have some privileges over, the average visitor. And that is for example, sometimes you're allowed to visit outside of visiting hours, and it could give you potential access to the ICU where it's normally immediate family only. They're very strict about it for a good reason. So as representing clergy as chaplains, you might have an opportunity to go visit inside the ICU, provided you do what Peter did and introduce yourself so they know who is this person visiting. So again, those are some possible extra privileges you might have, but just keep in mind, you're not hospital staff. Remember, you're on your turf, you're on their turf, not theirs. So don't assume that you have a right to do this and that. Don't be pushy. Preaching to the choir here, but I've heard some stories, unfortunately, of a chaplain with a different organization that just thought, he was on scene and in charge and did some real inappropriate things, and I was shocked by it. So again, we're there to be polite, and we're trying to be helpful. Something I can tell you is, when I was serving as a hospital chaplain, I found that the nursing staff, once they know who you are and they see what you're doing, they'll come to realize you're an ally, not somebody getting in their way. That right there is huge, because maybe that person is antsy, they're lonesome, they're scared. And if you're there with them that calms them down, entertains them for a while, however you want to put it. And that could be like they're getting an extra staff member or somebody else that helps, accomplish their mission. So you can be a great ally because maybe you're fulfilling something they can't do because of time restraints. So just remember that you can potentially be seen as an ally, and that's a really good opportunity. Signs. There's signs all over hospital rooms. Just be mindful of those. I'll just point out a few where it says high fall risk. It might be your buddy you've known for a long time. It's like, this guy walks fine. I saw him at the post 2 weeks ago. And he says, can you walk me down to the bathroom, my room, or can we take a walk down to the cafeteria? Well, if he's your buddy, you're going to say, heck yeah, let's go, man. But the reason that's there is for a reason. Maybe they didn't break a leg or something, but maybe because their blood pressure is low, maybe the medications are on. Normally they could walk fine, but under their current status, because maybe blood pressure, dizziness, meds, they could stand up and pass out and keel over and smack their head and break their head open. So be extremely sensitive to these things. They say, hey, I need help to go to the bathroom. Can you help me, Peter or Frank? Ask first, because you might be putting them in danger. It's not that you're not well-meaning, because I know you are, but those signs are there for their protection. Isolation room on the top right there, do not enter. Isolation could be for a couple reasons, either to protect them from your germs or the other way around to protect you from theirs. They might be immunocompromised and you don't want to give them what you have, or they might have something contagious. Usually there's signs on the doors that say, put on gowns, mask, or whatever. If any doubt, you're not sure, just ask the staff. They'll be glad to tell you, okay, you need to do this or you don't need to do that. The fluid restriction, that may seem like a strange one, but be sensitive to that. You might walk in and might say, I'm really thirsty. Can you get me refill my water? Could you go down to the cafeteria and buy me a Coke? That's what I usually have at this time with my lunch. Do you mind? That's there for a reason. Maybe because their stomachs are upset, they're dealing with nausea, or maybe they have things like fluid overload from congestive failure, and they're trying to keep tight tabs on their fluid intake. So again, just abide by the signs, and when in doubt, ask. As far as isolation and protective equipment, these would be, some examples. This is an obvious one. Always wash your hands before you go in and as soon as you come out. I'll even wash my hands in the room before I walk out of the room, because you don't want to take those germs home or wherever you might be. Again, the gown and gloves, be guided by any signs or what they might tell you. Again, don't do anything without asking first. Just some visitation etiquette. Peter had some great ideas here. Again, when the patient is sleeping, you generally don't want to wake them up. Keep in mind if you've ever been in the hospital, it's normally extremely sleep deprived. They wake you up at all hours of the night, check your blood pressure, take blood. Maybe you're in pain. So sleep is hard to come by, and you don't want to interrupt that sleep. Like Peter said, if they're asleep, you can leave your business card or a note. Hey, they know you came by. That right there is great. Even if they missed your visit, they're going to be so happy that you just came by. And if he has your phone number, they could call you back if they're feeling up to a visit. Another good point, when there's more than one patient in the room, it's okay to go over there and say, hi, how are you doing? And just came to visit your roommate or whatever, and it might be an opportunity, or at least you're acknowledging them. It's a very polite thing to do. So that's a good thing. Again, it's just reiterating the sleep deprivation issue. Something about Bibles. I remember a chaplain once telling me about Christians and their 10-pound study Bibles. That's going to send a pretty scary message. If you walk in with a Bible that weighs 10 pounds, talking about the big study Bibles, that's not what you want to be bringing into the patient room, because that sends a message that you're there to put on a class or lecture them or something like that. And some people, you got to remember, they might not be comfortable with that. So if you're going to bring a Bible, that's something that you normally do or might be appropriate. Bring a small one if you can. There's a time and place for everything. So I know I kind of make a joke about the 10-pound Bible, but it could kind of send a message and might make somebody uncomfortable. That's all. Now, something about spiritual care, specifically in the healthcare settings. Again, it needs to be their agenda for the visit, not ours. So we're there to listen more than we talk. So if you don't spend most of your time listening, then you're not doing your job. And if you don't know the person well, find out what their worldview is. Don't assume that they have the same beliefs in you. They might not have your same spiritual beliefs. They may not even believe in God, that, anything in between. So try to find out if, ahead of time is good. But if you're not sure, ask. Don't ever assume what their worldview is, because it might be very different. And we want to be polite and respectful of that, whatever it might be. Pre-surgical visits. Peter put this slide together, and I thought it was some great advice. I just had surgery myself a couple of weeks ago, and I get this. They have a very tight schedule in pre-op. There's all kinds of medical personnel that need to come in and out and get everybody ready. Extremely busy. Typically, they're only going to let in the immediate spouse, and only for a limited time. So it's probably 9 times out of 10, in my opinion, it's probably going to be best to try to arrange a meeting with the patient, maybe the day before, a few days before surgery. And then you can have some time with them, talk about whatever they want, because in the hospital preoperatively, they usually can't accommodate one more person. It's just too busy. They don't have the room. So, you might be able to maybe sit in the waiting room with the family members outside the OR. That would be appropriate. But to go back in with the patient is probably not going to happen. It's just too busy. So I like what Peter wrote here. It's probably good to make contact beforehand. And then you could offer, do you need me to, come sit with you in the waiting room? You're obviously not going to be in the pre-op, and definitely not in the OR. Now, something about convalescent hospitals or care homes, those types of facilities. These are more typically for the people that are more severely disabled, that can't care for themselves, or maybe they're too heavy a burden for the families to care for anymore. And this is especially true with people with things like dementia and Alzheimer's. These, and someone wanted to point out that may not be as commonly known, is these potentially sometimes can lead to aggressive behavior. It doesn't mean they're a mean or bad person, but that's part of the disease process. It doesn't affect all of them, but they can be very unpredictable, and sometimes they could be very aggressive and even strike out at you. So try to find out what you can ahead of time, and just be cautious. Just be more on your guard than you might not, than you might be ordinarily. What's different, about these type of facilities compared to acute care facilities, they're going to have decreased cognitive function. They might be confused. They might have disabilities, like they might not be able to walk anymore. Maybe they have a stroke, they can't move one side of their body, things like that. They may feel abandoned. They may feel lonely. So in these cases, longer visits would be more appropriate. Maybe in those settings, maybe reading, some Bible passages to them, or Bible story might be something they like, depending again on what they want. Or maybe they want you to read something out of a magazine to them. You never know, but you'll have more opportunities to have longer visits and do things like that, because it's a very different environment. Now, 2 things that are probably familiar, but I want to point out there are some specific differences just for the sake of building our understanding and vocabulary. There's palliative care and there's hospice care. Now, palliative care is basically for supporting the patient and dealing with symptom management with somebody with serious illness, regardless of their prognosis. So it aims to improve their quality of life, and it's there to help them be as comfortable as possible. So in other words, it doesn't matter whether they're 40 or 90 or something in between. It doesn't mean it has to be a fatal illness. It could be something that's lifetime chronic. We'll go into examples of that. Hospice is on the other end is different. It's specifically to care for individuals who are nearing the end of their lives with a prognosis of 6 months or less. That's typically what it's for, and the insurance companies will cover. So that's the difference. Hospice is end-of-life care. They're focused on comfort, pain management, emotional support, end-of-life support, and they do a very good job in helping prepare the family for the end. They provide spiritual care too. They have chaplains that come visit. They do a good job in providing materials and teaching on what to expect as death becomes closer and closer, the changes they're going to see physically, emotionally, things like that. So they do quite a good job with those types of things. So that's the difference between palliative care and hospice care. Does it make a big difference when you go to visit that person? No. But I just want you to know that the purpose and the definitions of those two terms there. Something that's you may sound familiar from the old work of Elizabeth Kubler-Ross decades ago, where the 5 stages of grief. Again, not something you have to memorize and be an expert on, but if you can find an article on it or just read this, slide over yourself and kind of digest it. But these are the phases that she discovered were typical that patients go through. Doesn't mean everybody's going to go through exactly the same order in these exact same steps. And it doesn't dictate how long they're in each, because everybody's an individual. But this is just typical of what they might go through. Why would it be helpful to us to know? So that you could be aware that maybe somebody's going to be angry. Maybe somebody's in complete denial. Maybe later on they finally accept their terminal diagnosis, etc. So you're going to encounter them at different phases, at different stages. And just keep that in mind. So when you see somebody that's really angry, you won't say, gee, are they mad at me? Or did their spouse make them mad? Or you'll know that that's just part of the process that people go through. So being aware of that is helpful, because then you're not so shocked or surprised or intimidated by it. You realize, hey, everybody goes through this grief process a little differently and at a different pace. So just being familiar can be very helpful to all of us. Hospice programs are very good about providing brochures, little booklets on this type of stuff, so that the family becomes aware of these things. And I find that's really, really good because it helps prepare the family so that they know, okay, now I kind of have a feel of what to expect in the days or weeks ahead, as the case may be. And by preparing them, it lessens their anxiety, because then they know, okay, I remember the social worker telling me about this phase, or their breathing changes or whatever. So those are all good things. As I said, they're quite helpful. And in a previous class, we mentioned the book Good Grief. It's a tiny little book, very small. I think I bought a box of them for like $5 each. They can be real helpful to give to families as a gift, or maybe somebody that's lost a spouse recently. Maybe even more helpful than a card. And it's very readable, and it just kind of lets them know that, hey, what you're going through right now, that's normal. If you're feeling angry or scared or this or that, it reassures them that, hey, I'm not going crazy. What I'm going through is part of the process. It's normal. And I find that really, really reassuring to people, because they're going through such a huge loss. They may feel completely disconnected or confused. Am I losing my mind? They go through all these different emotional things, and it can be real helpful to be made familiar with things that are normal. So they feel like, okay, this is part of the process. I haven't lost my mind. I'm still in control. So they're good. Now, again, in these cases like hospice or palliative care, the focus is on comfort, not prolonging life. So, example, when you're in hospice, they're not there to, stop death or to extend your life. They're there to make you comfortable as possible during that normal end of life process. Now, that opens up opportunities for you as chaplain to maybe coordinate, or at least let your post know. There's things the post can do, like letting people know so they can visit, maybe delivering meals. When somebody's going through a crisis, just you dropping off, a pot of soup or something could be a huge blessing, because that's one less thing they have to worry about. That's a really nice thing people can do. Respite care. Maybe it's just a husband and wife, and the wife is exhausted. Maybe you can say, hey, I'll sit with John here for a couple hours. You get out of the house and go shopping or go to lunch with your girlfriends. I've done that. If somebody they just needed a break from all that, and they went out with some girlfriends for lunch, and it gave them a huge break. Or maybe the spouse just wants to get in the shower and take a nap. Just sitting with them could be a huge help. It gives them a break. You don't necessarily need any special training for that. You're just basically keeping them company so they can take a mental break. It could be a really good thing. Just some general principles, things to keep in mind. Keep in mind that, a lot of our post members do in fact have a home church, and they would be the more appropriate ones to notify in case there's a terminal illness or a funeral need for memorial service, things like that. Find out, do they have a home church, a synagogue, or whatever it might be? Maybe they do, maybe they don't. As chaplains, we're kind of filling those gaps. But if they have a church relationship, those are the appropriate people to get involved in. I remember at our national convention this last time, Deb Halter gave a wonderful talk. She was talking about funerals, and she was emphasizing how their church family should be the ones doing the funerals if they have that available. And I absolutely agree. They're the ones that know their traditions, know their families and stuff better than we do oftentimes. So they're a great resource. Just keep in mind that it's important that you don't have the legal right to share medical information unless they give permission. Or in the case of somebody that's unable to speak, their immediate family members are the ones that can give you permission to share information. I know we're all well-meaning and, hey, we want to let people know because we want them to get visits or friends to help out. But I'll just say, do I have your permission? Is it okay if I let the folks know at the post? Can I let your buddies know at the post? And they may say, oh yeah, that'd be great. I'd really appreciate it. Or they might say, no, I'd rather you not. This is private. I want to keep it private. That's their decision, not ours. So always, always, always ask before you share. It just becomes second nature to me. I always ask, do I have your permission to share? Would you like me to call your church? Do you want me to let the post know or whatever? Because they might say no, and you can get yourself in trouble in terms of ethics and legal. So you really want to know if you have permission. There's something called HIPAA, and it's basically a law in place. It says basically, bottom line, don't share any personal information without their or their family's permission. So ask first. This is a mandatory for training for anybody that's like a first responder or in healthcare. Every year you have to check off the box that you did this training, and they remind you you could get a jail sentence or a very heavy fine if you violate this. So it's not worth taking a chance. It's easy to ask. You can get yourself in trouble legally. So again, just a caution there. Now, prayers. Jim Jenkins did a wonderful presentation on prayers. So some of this will be familiar. It's assumed that chaplains, when they show up, they're going to pray, or that's what they come to do. Well, that's true that we do offer to pray, but we don't force it on anybody. That's so important. Granted, you expect and hope that you get the opportunity to pray, and the family may expect you to pray, but that might not be what they want. It might not be something that they're used to or comfortable with. So I want to give you the best piece of advice I ever got regarding this issue. I don't remember if I got it out of a book or a chaplain's class. I can't remember now, but I always ask the person, would you like me to pray for you now or perhaps some other time? Now, what does that do? That lets me know, would they like me to pray for them right there in person there, or not? Because when I was a hospital chaplain, I was surprised by how many times people say, no, thank you. If you just remember in your prayers, remember me in your prayers when you do your prayers tonight, that would be good. Because some people aren't comfortable with somebody praying out loud in front of them. That might not be their tradition, etc. And most people are quite polite and they appreciate your visiting. And so they probably would feel, I don't want to hurt this guy or gal's feelings by saying no. This gives them a way out that's very polite. Now they can say, oh, that's very nice. Thank you for offering, but can you do that later? Okay, now it lets you know that they're not comfortable with you praying out loud in person. So it's a great, great thing to always remember. And I do that unless I happen to know them and I know that would be appropriate. It's better to ask, can I pray for you now or perhaps some other time? And then you'd be guided by that. Now, what I say is by build a prayer, I emphasize that, build a prayer. I build my prayer based on my conversation with them. So I'll try to build my prayer based on the things they express to me in our short visit. If it's fear, if it's anxiety, or they just want to get better, whatever it is, by praying, building a prayer based on what they shared with me, they know that I actually listened and that I'm concerned about what they're concerned about. For some people, maybe that's not comfortable. Their tradition is that you read a formal written prayer. In some traditions, that's what's expected, and there's nothing wrong with that. I come from, I was raised Catholic, but now I have a Protestant tradition, and we do, what a Catholic friend of mine called it, spontaneous prayer. In other words, I build a prayer based on the conversation. Either one's fine. Just be brief, be patient-centered. Don't have an agenda on your prayers. Now you may say that, well, what do you mean agenda on your prayers? That sounds kind of weird. Well, unfortunately, I've heard that agenda might be like, this person doesn't believe it. Oh, Lord, I'm praying for this friend of mine, Peter, and he's really sick in the hospital. Make him feel better. And, he doesn't know God. Will you please knock some sense into them and help them to see that God's real and stop being stubborn. That would be an exaggerated but example of being manipulative. Or I've seen people do these long evangelical prayers, Lord, may he, find you and stop resisting you, and that may he believe this and that and that and that. That's not what you're there to do. You're not there to proselytize or manipulate. I've heard prayers of, like they're basically sermonettes, and they go on and on and on. That's just brutal. You need to be brief. It needs to be personal. You're not there to evangelize. You're not there to manipulate. I've heard things like, oh Lord, will you help him reconcile and stop being mean to his estranged daughter, and that he would call her and stop being stubborn. Again, I'm kind of exaggerating, but I think you know what I mean. Some people can be manipulative. They're trying to make the person do something or make them believe something. You just don't do that. So again, just like your visit is client-centered, your prayer should be patient-centered, no agenda. I'll give you an example. I think I shared this before. When I was hospital chaplain, I was, it's amusing to me now, but I'd ask so many patients, especially very elderly ladies. I'd say, I'd ask first, can I pray for you now or some other time? Yes, I would like prayer. What can I pray for with you? Will you please pray for Sparky or Kitty or whatever, their little beloved pet? Because maybe that's the only person they have in their life. They're more worried about their dog than they are about their own life or health. I was surprised. The only thing that worries me is my puppy. Can you please pray for my dog? You know what I did? I prayed for their dog, and that was like it meant so much to them. And I was glad I was able to pray for that dog, because that's what they wanted. That's what they needed. So keep in mind, just be open to where they lead you. And then lastly, I'm going to share before I turn it back over to Peter, just be aware of your limitations. We don't know everything. We don't have all the answers. It's okay to call on our colleagues, call on their church. Maybe they need somebody from a specific religious background or faith tradition, et cetera, et cetera. And one thing I want to bring up too is some people are naturally more squeamish than others. That's nothing to be ashamed of. I think more people are squeamish than not. And it's okay. For some people, the smells and the sounds and the sights are too much for them, and they're really, really uncomfortable to go visit somebody in a hospital. Or maybe they had a very traumatic experience in their own life, in their childhood, or with a family member dying in the hospital, and they can't get over that emotional trauma. That's nothing to be ashamed of. It's okay. That's why I say know your limitations, because maybe it's one of those cases. Let's say I'm really squeamish. I could call up, say, Chaplain Dale, and say, hey, buddy, can you make this hospital visit? They just had surgery, and there's going to be all kinds of wounds and vomit or something, and I'll pass out or get sick. Can you visit them for me? There's nothing wrong with doing that. That's why there's a whole group of us here. So if it's not something you're comfortable with, call one of your fellow chaplains that is comfortable doing that. And maybe you can repay the favor. Someday I'll do something for you. So again, if that's something that makes you really uncomfortable, or you have problems with that, please don't be ashamed. Just ask one of your colleagues to do that. I know a group like this, they'd be glad to fill in for you. And it's a good thing that we have each other. At the end there, we're going to have a little bibliography that I put together, and that's not mandatory reading, of course, but this books that I have personally read, and I found those among my favorites that were the most helpful. And the titles will kind of explain what it's about. Anybody want to reach out to me personally to talk books or anything, please go ahead and do that. I'm going to turn it back over to Peter.
Hey, Peter, we can't hear you. Turn yourself off mute.
Yeah, unmute.
Okay, I got it.
We hear you now.
Hospice care is really a good thing that has developed. And as hospice care developed, it has become big business. Back in 2014, it was reported that it was a $17 billion industry. In 2021, hospice was a $23 billion industry, according to a report by Bank of America, Global Research, shared with Hospice News. So this is big business, and it's a big growing business. So hospice care is needed, and hospice care is a good thing. And I want to say right up front that I am not against hospice care companies. I think hospice care companies are great, and most of them operate above board. However, as hospice care companies developed and competition for clients grew, they realized there was a niche market they needed to target. That segment of society, consisting of older veterans, is an easy target as they seek to expand their business. Hospice companies began to specifically target veterans. And from my research, these are for-profit companies that were specifically targeting veterans in addition to other hospice clients. So you have a lot of companies out there, and you have some that see the niche market now of veterans. And that's not wrong to go after veterans. Okay, next slide. Hospice care companies provide a good service, and most, I believe, are operating in good faith. While targeting and wanting to care for veterans is not necessarily a bad thing, I want you and our comrades to be informed consumers. In an effort to get the word out to veterans and their families, a representative from a particular hospice company may contact the VFW commander or you as a chaplain and ask to make a presentation either at department, at district, or at your post meeting. Or have you distribute literature on their behalf. They may come to you and say, this is what we do for veterans. And if you are naive, you say, oh, that's good. And you think this is a company specifically working for veterans. And next thing you know, you are promoting their business and you are being used in that way. Over the years, I've been contacted by specific hospice companies, first as a post chaplain, a district chaplain, and then as a state chaplain. In other words, if they could put in their communication with others that State Chaplain Peter R supports us and is a follower of what we do, that enhances their presentation. So I'm not sure the hospice companies that are targeting veterans, and this is the key, the hospice companies that are targeting veterans, I'm not sure that they provide anything more for veterans with regard to hospice care than any other hospice company. It's just that their marketing picks up that they are working for veterans. So as far as hospice companies care, they care for people by providing hospice care. And that care is the same whether you are a veteran or a non-veteran. However, when a veteran's family hears that such and such a hospice company works for veterans, immediately they think they're getting some benefit as a result, and that may or may not be true. Next slide. Keep in mind the sales pitch of hospice companies targeting veterans is designed to leave the consumer with the impression that they are in the business to honor and care for veterans. And I want to say that they are a for-profit company, and they exist to make a profit by providing hospice care. And their hospice care can be with veterans or with non-veterans. So they are a for-profit company providing hospice care. I'm not sure there's any significant savings to the veteran by using a company just because they say they honor veterans or they or a hospice care that that cares for veterans. There's really not necessarily any cost benefit, but the average veteran family thinks they're getting some benefit by going with this company over another one. The hospice companies targeting veterans say they will provide information and get the veteran VA benefits to help cover the costs. Providing information on VA benefits can and should be done by one of our VFW certified service officers, not necessarily the hospice company. So as a chaplain, you can help the family understand that by going through a VFW certified service officer, they will get the information they're needed and it'll be free. There's no extra added benefit by going through a hospice company. Next slide. Is there another slide, Frank? Okay, yeah, here it is. Today, when families hear that a company services and caters to veterans, they can automatically jump to the conclusion that they will be getting a discount or some special care. This may or may not be true. They should shop around, compare the services, compare the various companies, compare the costs. Hospice companies provide hospice care, and most of them do a good job. And I'm not too sure I could tell one is better than the other from my vantage point. Just because they say they care for veterans or honor veterans doesn't mean there's an added benefit to the family. As VFW chaplains, we should be involved in the end-of-life care of our comrades. And the family sometimes will come to us. Whether in the hospital or care facility or at home, we should be there to offer supportive care to dying comrades and their families. Help them and their loved ones as they transition to glory and assure the person that he or she will not suffer or die alone. So we want to be there during the transition time. Hospice companies know you are crucial and you could be used to help them land a sale. So I want you to be aware, be very careful you don't put yourself in that position and do not get used by a hospice company. Now, I had 3 different hospice companies contact me, and each one wanted my endorsement. Do not endorse. Stay away from that. Now, I have given a letter or that I wrote, an article that I wrote, and part of that article has a letter involved with it of choosing a hospice care when the time comes. Next slide. Is there another slide there? Yes. So check out this letter, choosing a hospice care when the time comes. To me, this letter is probably the best I have come across to help guide families. And I have copies of this in case anybody ever asks me. So they'll ask me, Chaplain, what do you think? I stay away from giving any information on any hospice care company. However, I will give them this. Now, what this is, this letter on choosing a hospice care. Inspired by the recent hospice articles and the latest Frontline Being Mortal, Chaplain Barbara Muntz decided to pen a letter to her 4 children about selecting her hospice care when the time comes. She offered to share this letter in hopes of contributing to the conversation on speaking to your loved ones about hospice care. So these are personal recommendations from this gal, Barbara Muntz. Now, what she says here to her children, as the time approaches for us to make choices about my health care, I realize that one of the decisions that you may have to face is whether or not I should be admitted to hospice care. After working with countless anguished families through the years, I'd like to offer some guidelines that might help you. Let's get one thing clear at the outset. Choosing hospice care is not a death sentence. It is, in fact, saying yes to life in every possible way. If I have a life-limiting condition like cancer or Alzheimer's or, or end-stage heart failure, hospice can help all of us be together in the most important ways. Lots of folks I know say that hospice is a good thing, but just not yet. If you are wondering whether or not it is time for hospice care, my darlings, it probably is. So she's encouraging her children to consider hospice care when that time comes. Choosing hospice is one thing, but choosing the right hospice is another matter entirely. There are some things I want you to consider when selecting a hospice to provide my care. Here are some questions to ask. First question, to ask the hospice care company, are you accredited by a nationally recognized accrediting organization? Accreditation is not a guarantee, but hospices that seek accreditation are inspected more thoroughly and usually more often than those that do not. Second, how long have you maintained your accreditation? Hospices that have maintained their standing through multiple cycles of accreditation show that they have sustained the kind of quality needed to provide high-level care. Many hospices go through one accreditation survey, then they do not maintain the requirements over time. Look for a hospice that has been through at least 2 3-year cycles of accreditation, or even better, 3 or more cycles. So number 1, are you accredited? How long have you had your accreditation? Third, what has your average daily census been for the last 12 months? You would never have brain surgery at a hospital that only does 5 brain surgeries a year, right? Of course not. You would go to a hospital that does a ton of brain surgeries and does them well. The same principle applies to hospice. The more patients with my diagnosis that a hospice has seen in the last year, the more likely it is that the team has the expertise needed to ensure that I will get better symptom management and better care. Next question. How do you manage aftercare hours? And another one. What is your model of providing continuous care? Giving this to a family and letting the family do the research and ask the questions, let them make the decision and realize whether they cater to veterans or not should not be an issue. They all do that. They all take care of their patients. And if a patient is a veteran, yes, they will do some things. But if a patient is not a veteran, they will do some things. But keep in mind the sales pitch, and be aware that some will contact you because you then help them to sell their service to the families. So anyway, I give this to you for your advantage to look at, to have in your file. If the need presents it, to give it to families. So any questions before we end this for tonight? I think I'm past my time. Frank, did you want to say anything else?
No, sir.
Okay. If anybody has
This is Alan Perkins. May I add something?
Sure.
So 2 quick points. One, when Chaplain was talking about making sure that you know if the patient is there and what room is, I spend a lot of time with the chapel at the Bakey VA Medical Center, but I also spend a lot of time working in the lobby. And I frequently have pastors or chaplains come in, usually pastors, and they'll say something like, I'm here to see Brother Wilson. Well, I look at the roster and I have 4 Brother Wilsons. So, you gotta know that whole name and how they would be identified in the hospital. And the other thing is, when we're talking about hospice, remember that your larger, if not all of them, your larger VA medical centers have very good hospice care.
Yes.
And one of the things that they do is a program called No Vet Dies Alone, which means when that veteran is coming toward the end of his or her life, somebody will be with them in their room 24 hours a day to do whatever they need, whether it be read a book, pray for them, or just sit there and be a patient, a person in the room.
Good point, Alan. Good. Thank you for sharing that. Yes.
Deb, I made you the host again.
I think we can turn off the recording now unless there's any more questions. Otherwise, we can chat a little bit after I find it and turn it off.
Yes, I have my hand out.
Okay. Hello, Mr.